Alright guys, good evening. Can you all see me? Can you all hear me? A quick feedback. Hi guys, good evening, good evening, good evening. Right, so we'll start from where we left off yesterday. That is, we concluded the entire component of the breast disorder. So we spoke about various aspects of it, that how do you evaluate it. Hi Liaquat, good evening. Walaikum assalam. Okay, so let's continue from where we're supposed to start today. Okay, so today we'll start with the benign disorders of the breast. है ना? What happened to it? Sometimes it does misbehave, no? Okay. Think this is the one. Yeah. Okay. Right. So we'll start from where we left off yesterday. So आज हम बात करेंगे benign breast disorders की. तो let's start with the benign disorders of the breast. Okay. So until now we have discussed that if a patient comes to you in an OPD, you have to know that how do you evaluate a patient. We did the first one, that is the clinical examination, various forms of clinical examination. Then we went for radiological assessment. We did a cytology. We got a conclusive diagnosis. Based upon the diagnosis, we'll plan up for the management. So this is going to be the basis for the entire lecture of the breast. कि अगर कोई patient आपके पास आता है, if a patient comes down to you, what are the steps to be followed so that you reach to a conclusive diagnosis? As simple as that, right? Now, so yesterday we spoke about the entire context of the assessment program. Now, in this assessment program, you have something called as BIRADS. So I'm going to introduce to you our friendly radiologist who want to feel a bit more relevant. They want to contribute to the society. See, according to me, I'm not saying it, it's just my opinion. According to me, radiologists are a bit overrated, no? And they're like, I mean, they're glorified photographers. They take pictures, they report pictures. They take pictures, they report pictures. After a point, as a matter of fact, anybody can do that, okay? Don't take offense in it. But then still, they had a system which is called as BIRADS of the categorization that I have, right? So what does BIRAD stands for? BIRAD stands for breast. It is the breast imaging. It is the breast imaging. That is breast. One second, guys. It's breast imaging, reporting, and data system. Reporting and data system. Now, majority of the times, whenever they ask you an exam question, they usually ask you what does R in BIRAD stands for. Is it radiological? Is it radiation and all that? So it's breast imaging, reporting, and data system. That is what we call as BIRADS. Now, according to BIRADS, we have various components that have to be addressed, right? So what are the various components according to the BIRADS which are going to be addressed, right? Now, we have various categories. So you need to understand why did a radiologist put BIRADS into the picture. The BIRADS are put in the picture to report a screening program. As we all know, any patient who is above 40, currently it is recommended to go a screening for breast cancer with the help of mammography if the patient belongs to a general population. High risk population or a BRCA gene mutation positive patient needs to get an MRI done after every annual MRI after the 25th birthday, right? That is for high risk population. So what are the various categories that you have? So we have the various categories of BIRADS, and based upon the categories, what is its description? And based upon the description, what is the step that you're going to take in terms of management? As simple as that. Now, we have something called as BIRADS category 0. Now, what is category 0? Category 0 basically tells you it is an incomplete assessment. Category 0 basically tell you that it is an incomplete assessment. What is an incomplete assessment? A patient came for a screening. We did a mammogram. The quality of the image was very poor and we are not able to interpret the findings, right? On the other hand, let's say patient came with certain pathology in the breast, or let's say palpable breast lump, which was present on the right side, but the imaging was done on the left side, right? So you're not able to complete the assessment. Obviously, when there is an incomplete assessment, this time we would ask the patient for repeat imaging. So redo the investigation is the only logical answer that you can think about when it comes down to category 0. So category 0 is an incomplete assessment. The reason for incomplete assessment is the poor quality of the image. Either there is a poor quality of the image or there is a wrong breast imaging was done. To overcome that, you do a repeat imaging on this. This is a category 0. Then we have something called as category 1. Now, this is something that I want every single patient of mine who comes for screening should have this. Now, what is this category 1? Category 1 basically means it is a negative report. Now, negative report means there is no evidence of any pathology. There is no lump identified. There's nothing. It is negative for pathology. And that means it is absolutely fine. What will you tell the patient? You ask the patient to continue screening. So ask the patient to come back after next year. So this year the patient came, there's no abnormality, there's nothing. So ask the patient to come back next year for routine screening again. So you say continuous screening is the advice that you give. Then you have category 2. Category 2 is absolutely benign lesion. 100% benign. There's no problem at all. And this is what we call it as a category 2, which is an absolutely benign lesion. Now, when you have a patient in which radiologically your radiologist is screaming out loud and clear that this is only benign lesion and nothing else, so what do you need to do? You need to sit back and relax. Tell the patient, okay, fine, my radiologist is quite happy about it. Don't do anything. Come back next year and we will continue your screening program. We will continue our screening program. So we'll ask the patient to come back next year, get a repeat investigation done. That is a repeat mammography. That is on an annual premier scaling that we are doing, right? Okay, somebody is from Afghanistan. Hi, thank you. Welcome to our BLS series. I'm so happy, sometimes when you put in an effort and you do it genuinely, it reaches out cross borders and, a lot of people get benefited out of it. I'm so happy that you're able to use our BLS lectures. If you have any suggestions, you can always pump in here and we'll try to implement them as well, right? Okay, continuing on our BIRADS system, you have category 0, incomplete assessment, do a repeat imaging. Category 1, negative report, best result possible, continue screening. Category 1, benign lesion, radiologist sure. If a radiologist can be sure about benign, as a clinician, I don't need to worry at all. So I'll continue screening at the same time. The most tricky one that you will come across is going to be our category 3. Now, what is category 3? This is what we call it as probably benign. When I say probably benign, the probability of malignancy in this is less than 2%. Okay? So my radiologist says, sir, I think it is benign. I said, what do you mean you think it is benign? Sir, I'm sure, but I'm still not confirmed that it is malignant. So it is benign only. So I'm like, give me a percentage. He says 98% is benign, 2% it can be malignant. Now I cannot take a risk. If a patient is having some probability of malignancy, even if it is less than 2%, I cannot say patient go chill, come back next year, we'll do screening. So for this patient, what will you do? I'll ask the patient to come back after 6 months. So I'll ask the patient to come back after 6 months for repeat imaging. I'll ask the patient to come back after 6 months for repeat imaging. And if your exams in which they're testing your knowledge, your concept, and obviously competitiveness, this is the question they ask you. In BIRADS, if a patient is category 3, what will be your advice? Continue screening, repeat imaging after 6 months, or they'll say intervention, or they'll say surgery, some sort of nonsense they'll ask you. But the answer here, probably benign. You want to conclude it. I don't want to wait for another year because anything can happen and you have some probability of malignancy. I will go ahead with repeat imaging. Then you have category 4. Now, category 4 is actually suspicious of malignancy. It is suspicious of malignancy. Now, when I say the suspicious of malignancy, there are three subtypes: 4A, 4B, 4C, less than 10%. Then you have 10 to 50%, and 50 to 90%. Right? So probability varies from anywhere between 10 to 90% probability of having malignancy. Now, if a radiologist can suspect a malignancy, as a clinician, I know it is for sure there's something behind it. So as we learn in a triple assessment, I will go ahead with true cut biopsy. I'll go ahead with true cut biopsy. I'll go ahead with true cut biopsy. So suspicious of malignancy, go ahead with true cut biopsy. Then you have category 5. Category 5 is more than 90% it looks like malignant. So highly suggestive. It is highly suggestive of malignancy. It is highly suggestive of malignancy. Again, to conclude the results, go ahead with true cut biopsy. Go ahead with true cut biopsy, right? So you have category 0, which is an incomplete assessment. Do a repeat imaging. Category 1 is negative. Ask the patient to come back after 1 year. Benign after 1 year. Category 3, probably benign. And this is where our exam question is going to be present. I repeat again, if at all they want to ask you one trick question from your BIRADS, because radiology is not that tricky, so the only thing that I want to make a question out of it will be from this context. Okay? So if at all they want to ask you one exam question, that is going to be probably benign, which is going to be after 6 months, do a repeat imaging. Okay? Category 4, suspicious of malignancy, do a true cut biopsy. Category 5, highly suggestive malignancy, do a true cut biopsy. And the recent addition to BIRADS is category 6, which is biopsy proven malignancy. Which is your biopsy proven malignancy. This is your biopsy proven malignancy. Now, if there is a biopsy proven malignancy, what is your management? Then here you will go ahead with stage wise management. There is a stage wise management that is going to happen, right? So these are the various components that you can see on a breast imaging and reporting and data system. So according to BIRADS, these are the various categorization, but more importantly, this part is more important. You should know that if you have a category in which there is described as a clinician what you should do, and this is what is more important for us. Clear? Okay. Now let's dig into a more detailed concept of the benign disorders. So we have a system for the benign disorders which we have put in place, and this system is what we call it as ANDI, right? Now, what does ANDI stands for? ANDI basically stands for there is aberration in normal development and involution of breast. So the ANDI word, Rachit, which point beta? The last point is category 6, which is a biopsy proven malignancy. How would you go forward with it? If there's a biopsy proven malignancy, then you will go with TNM classification. Based upon that, you will give staging. That is a stage 1 disease, is it a stage 2, stage 3, stage 4 malignancy. And based upon those stages, you have a tailored, management protocol that we'll discuss later. Okay? Guys, everybody who is listening down to the BLS program, we have 30 hours plus. I think around 36 hours we have covered. I have covered the entire thyroid chapter from starting to end. I have covered the parathyroid chapter. We have done the entire trauma completely from, trauma is done in a great detail, starting all the way from the primary assessment to that of the abdominal trauma. Now we are into our 4th season, or I can say the 4th chapter, that is breast. And as we continue to evolve, we'll continue to do so. Every single chapters or every single lectures, notes are available in my Telegram group as well as in our MedEd Telegram group. You can follow this on my Instagram channel, that is going to be the surgery guy. When you follow the your Instagram channel, you will already get redirected to our Telegram group, which is also by the surgery guy. It is by my name, that is Dr. Sandeep Reddy. You can find all the notes of all the series that we do. In fact, if you are preparing for your competitive exams, let it be NEET, INI CT or FMG exam, you have NEET specific notes, you have INI specific notes, you have FMG specific notes available on the Telegram. All these notes are my handwritten notes, so you will be able to relate to the video lectures that you see on the YouTube or on the MedEd app. Okay? Chalo. So let's continue on which we are talking about. So we now talk about the benign disorders in the breast, and the benign disorders in the breast is what we call it as ANDI, and ANDI stands for aberration in normal development and involution of the breast. Right? Now, how does the whole concept of ANDI came into picture? Earlier, when the breast disorders were being classified, they said let's classify the breast disorders into various components. One that is because of hyperplasia, one that is because of hypertrophy, one that is because of inflammatory disorders, one that is because of chronic inflammatory disorders, one which is non-specific, one which is chronic inflammatory non-specific. So there were multiple classifications. Then they said benign lesion, then you have benign neoplastic lesion, malignant lesions. So there was a lot of components which are put together. Now, to make the life easier, now we say that the breast disorders exist in two forms. Either it is malignant or it is non-malignant. In non-malignant, all the spectrums are covered from a benign lesion to an inflammatory lesion, and that is what your ANDI is trying to tell you. Right? Now, when you look at the ANDI, histologically, so based upon the HP findings, when you look at the ANDI exists in various forms. You can have disorders which are only associated with hyperplasia. You can have disorders which are associated with fibrous component. You can have disorders which exist in a cystic form, like a simple breast cyst. You have papillary disorders. We have the papillary disorders, and then you have the adenomatous disorders. So when you look at the ANDI spectrum, ANDI covers all these disorders. There's hyperplastic disorders in the breast, hyperplasia, increase in number of cells, basically fibrous, it is a fibrotic component, usually as a result of chronic inflammation, simple cystic form, the papillary growth patterns, adenomatous, adeno is glandular, oma is tumor. So glandular tumor which are benign in nature are also considered in your ANDI's component. Right, so when you look at the ANDI's categorization, in the categorization we have the age related categories. So based upon the age, we have the disorders that are usually seen in the patients. Right, now if you look at the spectrum of the age, normally we can say age between, most of the breast disorders start from age between 15 to 25 years. Right, now, why not under 15? The normal thelarche itself is 9 to 11 years. No, under 11 years, the breast is not there. So from 11, the breast starts forming. By the time it becomes matured, or let's say it starts forming or evolving better, it's 15 years of age, and that is when the patient will start, having pathologies in the breast. Obviously, under 15, the breast is not going to develop properly. So how can you have pathologies which can, I'm not taking out the entire picture, but usually the disorders start after the age of 15. Okay? Now, in the age group 15 to 25, you will experience the disorders which are like fibroadenoma of the breast, the fibroadenoma of the breast. You have the fibrocystic disease of the breast. So you have the fibroadenoma, you have the fibrocystic disease. Then there is breast cyst, right? The other disorders also, example like virginal hypertrophy, all that is going to be present. Aishman beta, we have told you before also, I'm repeating again, in trauma, we have not done the urogenital trauma. That is the injuries, that is renal injuries, ureteric injuries, bladder injuries, urethral injuries, all that will be covered in our urology. So urology is going to be start to the end involving every single topic. Okay? So don't worry about it. So as we look across here, in the ANDI, based upon the age group, that is age between 15 to 25, and the disorders that it is going to cover up. The disorders that it is going to cover up is going to be the fibroadenoma of the breast, the fibrocystic disease, as well as the breast cyst. Okay? Right. The second age group that you will see is going to be between 25 to 40 years, which is the most happening age for breast disorders, right? Most of the disorders or most of the benign disorders that you will see is going to present in this age group, and this is the same age group where the malignant spectrum also starts to kick in, especially at the other half of the third decade, that is for 35 and above, right? So here you will have disorders like fibrocystic disease of the breast. You have the fibrocystic disease of the breast. You have the fibroadenoma. You have the fibroadenoma. Conditions like breast cyst. Another very interesting condition that we'll discuss in detail is going to be your phylloids tumor. It is going to be the phylloids tumor, as well as a condition which is called as duct papilloma. So most of the disorders that you see in the breast usually exist in this age group of 25 to 40 years. And then you have disorders or benign disorders which are usually seen in age above 40 years, right? So in age above 40 years, again you have the fibrocystic disease. You have the fibrocystic disease. A condition called as duct ectasia. A condition called as duct ectasia. Another condition which is called as duct papilloma. So you have duct ectasia as well as duct papilloma, right? So these are the various conditions that you will see in age-related categorization. Now what is interesting for us to know is, if you have a patient between age 15 to 25 years, in the competitive exam, they'll ask you which is the most common disorder at this age group. The most common disorder at an age group between 15 and 25 is the fibroadenoma of the breast. So obviously you have a young female with palpable breast lump, hypermobile, painless, smooth surface, all that goes in the favor of fibroadenoma of the breast. Now, if you have a patient who is between 25 to 40 years, the most common benign disorder that you will face in these patients is going to be the fibrocystic disease of the breast. Now, same context, if you have age above 40 years, the most common disorder that you will see in this age group, the most common disorder that you will see in this particular age group is going to be the fibrocystic disease of the breast. Right? It is going to be the fibrocystic disease of the breast. But what is there for you to remember? Okay, this is all is good, cool. But what you have to understand, that there is a disorder which is age specific, and I want you to remember this. For example, when you say the age 15 to 25, remember fibroadenoma. Okay? Young female, I want you to remember fibroadenoma. 25 to 40 years, remember phylloids tumor. So usually the phylloids tumor will be present in 25 to 40 years. And there's a condition called as duct ectasia. And remember, this condition usually exists in patients above 40 years. A similar disorder that I would like to add in age between 25 to 40 years, just add here, this is your Zuska's disease. Now, Zuska's disease is a condition which is called as a periductal mastitis. It is very similar to duct ectasia, but there is no ectasia. So, patients presenting with features of periductal mastitis with normal ductal architectures are Zuska's disease. But if there is an ectasic duct, that is irregular, dilated, multiple ducts are present, then the answer becomes duct ectasia. Okay? So, as my students, I don't want you to goof up on Andy. So, Andy is a beautiful structured program. It tells you that if you have a patient with a disorder in a breast, you can identify them as two conditions: either it is malignant or non-malignant. If it is non-malignant, it can be hyperplasia, fibrous, cystic, papillary, or adenomatous. All these are clubbed together in one single classification called as Andy. And Andy says, with respect to age, you can expect these disorders, and this list is very, very important. Is that clear? Okay. If you're clear with this, nothing more is important when compared to the discussion on Andy, right? So we have covered all your exam questions as well. We have given you basic concept of Andy. We have told you that how do you classify it, how do you look at it. Now this is how you're supposed to prepare yourself. Okay? Now, what I'll do is I'll take the important disorders and then we'll try to understand and analyze all of them put together. Right? So we have our 4 common disorders, that is the fibroadenoma of the breast, the duct papilloma, the duct ectasia, and the phyllodes tumor. Now, this is the right point if you want to ask any questions, any queries. Quick feedback, guys. Quick feedback. Any questions, any queries? Waiting for your components. Can we move on? Quick feedback. Quick feedback. Okay, helix, we are there. Clear? Okay, chalo. So this table is going to be quite important. Just give me a second. A small adjustment here. Just hold on for a second. Okay. Guys, give me 1 second. There's some technical issue. I'm just sorting it out. It's not allowing my screen to relay properly. Just 1 second. Right. So I think we're back on. Right. So we'll be discussing about all these in a comparative data. So let's quickly look across here. So when you talk about the condition, that is the fibroadenoma of the breast, as we have just discussed, this is usually seen in age between 15 to 25 years, right? Duct papilloma can be seen between 15 to 25 to 40, as well as 40 and above. So usual age of presentation of duct papilloma is between 30 to 50 years. Duct ectasia is usually seen in females who are above 40 years, and phyllodes, as I told you specifically, is seen in age between 25 to 40 years, right? Now, this is going to give us a very clear-cut view that when you're looking at a patient who has come to you clinically, or let's say patient has arrived to you on your OPD, based upon the age and obviously other symptoms as well, you'll be able to predict or make a logical diagnosis just by looking at the age itself, right? So age is very, very important. Now, where does the fibroadenoma originates from? Remember, it is going to originate from the lobules of the breast. So if you want to know where exactly are the lobules, what is a lobe, what is a lobule, what is a major lactiferous duct, what is a minor lactiferous, what is an ampulla, what is a terminal duct, you need to refer back to our first lecture of breast anatomy. Every single thing is clearly explained down there. I would highly recommend you, if you have not seen, go back there, watch that video. You will know that what are the various points or various anatomical components of the glandular structure of the breast. Duct papilloma arises from the major lactiferous duct. It arises from the major lactiferous duct. Duct ectasia also involves your major lactiferous ducts. It also involves the major lactiferous duct. Phyllodes tumor will have a mixed origin. So when I say mixed origin, this is going to involve the lactiferous duct as well as the lobules of the breast. So phyllodes tumor will have a mixed origin. So it will involve both the major lactiferous duct, minor lactiferous duct, as well as lobules as well. So what are the characteristic feature when you talk about the fibroadenoma? Now, as the name itself says, fibroadenoma. Fibro means fibrous, adeno means glandular, oma means tumor. So it is involving both fibrous tissue as well as the glandular tissue. So this is going to have a mixed origin. So it's a mixed tumor. So it has two different components. So I would say this is an example of a mixed tumor. The same validates for your phylloids tumor also. Phylloids is also an example of a mixed tumor. Phylloids is also an example of a mixed tumor. Why we say mixed? Sorry. It is going to involve it is going to involve both mesenchymal as well as epithelial component. Hence, phylloid tumor is called as a mixed tumor. Now, phylloids originally, when it was formed, it was called as that very common word that is called as cystosarcoma phylloids. It was given the name as cystosarcoma phylloids, right? Now, when I say cystosarcoma phylloids, you look at the word sarcoma, right? The word sarcoma denotes that it is malignant. But originally, phylloid tumor are not. I'm not saying it is 100% benign, but remember, 95% of the phylloid tumor are benign. Only 5% of them are malignant. So tumor which is predominantly benign, calling it malignant, do you think it is justified? The answer is no. So hence now the term sarcoma is completely dropped. So sarcoma term is no longer used. Now we simply call it as phylloid tumor, or it is also commonly called as the serocystic disease of Brodys. It is also called as the serocystic disease of Brodys, also called as the serocystic disease of the Brodys. So it's a mixed tumor. 95% of them are benign, only 5% of them are malignant, and this is the serocystic disease of the Brodys, right? So this is with respect to the phylloid tumor. Now, what are the other characteristic features that you have in fibroadenoma? It is a mixed tumor. It is having a nice capsule that is capsulated. It usually grows only 2 to 3 centimeters in size. So usually the size of the phylloids, the fibroadenoma, it is going to be only between 2 to 3 centimeters in size. So it's a mixed tumor. It has a nice capsule. It is 2 to 3 centimeters in size, and very important, it does not have any local infiltration. So hence it is hypermobile. Now, because it is hypermobile, they have given a characteristic name for fibroadenoma. The nickname of the fibroadenoma is what we call it as the breast mouse. Now, because it is so mobile that when you want to palpate by fixing the lump, you want to fix the lump so that you'll be able to feel it. Every time you try to hold, the lump slips away. And that is because of its hypermobility, the name is given as breast lump. Now, when it comes down to duct papilloma, now something really interesting that we need to know about the duct papilloma is, now imagine that this is your major lacticiferous duct. The major lacticiferous duct owes its contractility to a specialized epithelial cells, and these are what we call it as the myoepithelial cells. And the contraction of the myoepithelial cells usually allows the secretions in the breast to move into the nipple. Otherwise, obviously, there is nothing, there's no pump, there is no mechanism by which a secretion which is present in the lobule can move forward. The only way it can move forward is these myoepithelial cells, which are arranged in a concentric manner around the duct. When they contract, they allow, it's like a peristalsis, no? So they contract in a rhythmic manner, they allow the content to move forward into the nipple. Now, when you look inside, you have these normal epithelial cells. So these are the normal epithelial cells which are present inside the major lacticiferous duct. So they are usually the tall columnar cells which are going to flush the secretions out and keep the duct also secreted, right? So outer covering is your myoepithelial cells, inner there is a normal epithelial that is present, and in between these you will see wherever there is a gap in the myoepithelial cells, the blood supply to the major lacticiferous duct comes through these junctions, and they supply blood to every nook and corner of the major lacticiferous duct. They supply blood to every nook and corner of the major lacticiferous duct. Now, when there's a papillary growth that is going to happen, you will see that one of these cells which are present, they become polyploidal. So they continue to grow and they become extensive growth like this. Now, as they continue to grow, they are able to secrete a growth factor called as vascular endothelial growth factor, which is going to draw its vascularity from the blood supply of the major lacticiferous duct, and this papilloma becomes extremely vascular. Now, the problem is, whenever a blood supply or a blood vessels are formed under the influence of vascular endothelial growth factor, which causes or promotes neovascularization, the problem is that it creates or forms very friable blood vessels. Now, you know, breast is a pendulating structure. Now, because it's a pendulating structure, every time the breast is going to move, the duct is going to move. Every time the duct moves, the papilloma gets disturbed. Whenever the papilloma gets disturbed, these blood vessels are so weak and friable that they are going to burst open. When they burst open, they are going to bleed. And when they bleed, they will present to you as bloody nipple discharge. In fact, the most common clinical presentation of a patient with duct papilloma is going to be bloody nipple discharge. So when you look at the characteristic feature of this, you will see, number one, it is hypervascular. It is hypervascular. It is usually a solitary lesion. That means within a duct, you will only see one single lesion. Another one, it is going to be present, or it involves only one duct. So as we have understood before also, that there are around 10 to 15 TDLUs, that is terminal ductal lobular units, right? Out of those 10 to 15 TDLUs, only one of the TDLU component will have the papilloma. So they are hypervascular, they are solitary, they involve one single duct, and they usually present as bloody nipple discharge. Right? And remember, the size of the papillomas are usually less than 1 to 2 centimeters. So even if they are formed, no, clinically it becomes very difficult for us to diagnose because they are not even palpable. You're not able to palpate these structures as well, right? So this is the orientation that you should know in the context of duct papilloma. So these are the characteristic features of duct papilloma. So when it comes down to duct ectasia, so look here in duct ectasia. Now take this as the representation of the breast, right? Now just for the sake of understanding, let's say these are the various TDLUs that is present, that is terminal ductal lobular unit. I'm just for the sake of understanding, I'm drawing one so that you understand it better. So these are the ampullas, this is the major lacticiferous duct, these are the minor or the branch lacticiferous duct, these are the various lobules which are present. So there are, in a single breast, there will be around 10 to 15 TDLUs that are present. For the sake of our present, discussion, I'm just going to draw 2 or 3 TDLUs so that we get oriented to what we are trying to tell across here, right? Now, this is the normal representation of a terminal ductal lobular units. All of them are opening into the nipple. Everything looks fine. There's no problem at all. But suddenly, there is duct ectasia, right? Now, initially, they were thought that duct ectasia is under the influence of smoking, but now we do not consider smoking as an important risk factor or an attributed risk factor for duct ectasia. So it's basically an idiopathic ectasia that you're going to see. So what is basically, or what do you mean by duct ectasia? In duct ectasia, you see that this major lacticiferous duct which is present, this major lacticiferous duct gets irregularly dilated. You see this major lacticiferous duct, the word ectasia means irregular dilatation, but the dilatation is not that severe. It is usually involving less than 50% of the circumference of the duct, right? Now, these ducts which are uniform has now become ectasic, they become irregularly dilated. So what is the problem? Normal duct has the myoepithelial cells which are present on the outer surface. They're strong, right? They contract, they propel all the content which is present in the duct into the ampulla. From there, the lymphatic channels are there, they get absorbed. In a patient who's having duct ectasia, you see the duct is getting stretched, it is getting dilated. So obviously the myoepithelial cells become stretched, they become thinned out, they become weak. Now, if the myoepithelial cells become stretched, thinned out and weak, obviously these ducts will not be able to propel the content into the forward direction. Now, as they are not able to propel the content into the forward direction, you see all the secretions which are present, inside the breast will now start to accumulate inside the duct. Correct? So in a duct ectasia, the problem is there is stasis of content or there is stasis of secretion within the duct. Now, as these secretions will continue to pool, they will continue to precipitate. Now, as they continue to precipitate, they are now going to clog or block the entire ductal system. Now, as they clog or block the entire ductal system, what is going to happen? This is now going to form a precipitate like a foreign body. Now, whenever there's foreign body inside, the body know only one way to respond. It causes inflammation. So what is going to happen? This is now going to result in severe inflammatory response. You see, there's a severe inflammation that is going to occur around these ducts, not only inside but outside the duct also. So there's periductal inflammation. So here, one of the major things that you will notice is development of periductal mastitis. So the characteristic feature of duct ectasia is irregular dilatation that is going to result in stasis. That stasis will result in precipitation, and that precipitation will cause inflammation. Will it be a one-time inflammation or will it be a repeated inflammation? Now we all know that this ectasia is here to stay. Because the ectasia is irreversible, the secretions will continue to pool. As they continue to pool, they will continue to form all these components, that is precipitates. And as there is precipitate, it is a foreign body, hence there will be inflammation. As long as ectasia exists, the same period you will notice that it will result in inflammation. So it's a chronic inflammation. So you need to understand this periductal mastitis will result in chronic mastitis. So duct ectasia is a condition where a patient is going to face chronic mastitis. Here the patient is going to face chronic mastitis. Clear? So this is with respect to the characteristic feature of each individual component. Let it be your fibroadenoma of the breast, or is it the duct papilloma, the duct ectasia, or the phyllodes tumor. Now when you look at the probability of malignancy, the fibroadenoma usually do not have any component, or it has competency development of malignancy. But if the size of the fibroadenoma, we say if the size of the fibroadenoma is more than 5 centimeters, then we call it as the giant fibroadenoma. Then we call it as the giant fibroadenoma. And it has been noticed that if there is a giant fibroadenoma, I am saying the probability of malignancy exists, but then it is low possibility. I'm not ruling out. Yes, fibroadenoma is less than 5 centimeters. You don't need to worry at all. Chill, relax. Ask the patient to go back home. Relax. Don't worry about it. No need for surgery. Patient can live her life absolutely fine. But if the size is more than 5 centimeters, and there are other things like family history or breast cancer is there, if there's some atypia on an ultrasound or on an imaging, there's some form of irregularity, all these adds on. But on a safer side, I can say less than 5 centimeters, chill, relax, no problem, have a nice life. Nobody's going to bother about it. More than 5, yes, the patient has to be a bit vigilant, right? Duct papilloma, on the other hand, has no possibility. I mean, let's say absolutely benign. Ectasia is absolutely benign. As we told you, the probability of malignancy in a phyllodes tumor is 5%. 95% of them is going to be benign disorders. It is going to be benign. Now, how does a patient of fibroadenoma is going to present to you? Now, the fibroadenoma of the breast, the patient will present to you with lump in breast. So when you talk about this lump in breast, it is going to be an incidental finding. It is going to be an incidental finding. When I say incidental finding, the patient would say that there is no symptoms, there are nothing. I was taking a bath, and while taking a bath, when I was rubbing the breast, I felt the lump against my hand. So it's incidentally found, right? Now this lump in the breast is incidentally found. It is going to be absolutely painless, and patient will say that probably from the day I felt it till today, it is no increase in size. So I can go ahead and say it is gradually increasing in size. It is gradually increasing in size. So I ask, obviously I've decided the patient to examine. I take the patient for clinical examination. When I take the patient for clinical examination, what do we understand? Okay. So clinical examination, when we take the patient for clinical examination, the first thing I notice that it has got a smooth surface. Now, smooth surfaces are usually seen whenever you have a lesion which is encapsulated. Right? How to grade this, sir? On what basis are you asking about grading, beta? Med motivation? No. I didn't get your question. If you can rephrase your question, I'll be able to help it. Sir, please a little Hindi. बेटा लिटिल हिंदी क्या पूरा हिंदी कर देंगे, कोई टेंशन नहीं है. अगर आपको सवाल कोई डाउट है, कुछ समझ में नहीं आ रहा, आप पूछो, ऐसे बता देंगे. ठीक है. एंड ऑल दोज गाइज नाउ हु आर लिसनिंग, गाइज, okay, if you have a doubt, you ask in your chat box. Okay. Now, if you want the explanation in Hindi, just so, sir, I have this doubt. Kindly explain this in Hindi. I will do so. All those students who are from Andhra, Telangana, if you have doubts and you want me to explain in Telugu, you can go ahead and ask it. I will explain in Telugu. Evana doubt unte Telugulo adagandi, Telugulo chepta. No problem at all. Same if you are a Kannada student and you want, you have a doubt and you feel that you might be able to understand better in Kannada, you can ask. I'll explain in Kannada. I'll explain you in Kannada. Absolutely any doubt that you have. Okay? I know only these many languages. I know Hindi, English, Telugu, Kannada. A bit of Tamil I understand, but I'll not be able to tell you in Tamil. I can understand Tamil if you speak so. ठीक है. So language barrier है ही नहीं. ठीक है. कोई सवाल है कुछ भी आराम से पूछो, कोई दिक्कत नहीं है. ठीक है. So the patient comes to you because it is capsulated. It will have a smooth surface. It is going to be hypermobile. It is going to be hypermobile. Now, when you palpate, no, it will have firm consistency. Now, clinically, you should be able to know that what type of, बेटा नेपाली हिंदी हो गया ना यार, तो हिंदी अभी नेपाली नहीं बोल पाएंगे यार, हिंदी बोल लेंगे. ठीक है. तो अगर हिंदी यार, आई थिंक ऑल नेपालीज डू अंडरस्टैंड हिंदी, सो वी आर देयर, विल टेल यू इन हिंदी, कोई दिक्कत नहीं. ठीक है. सो व्हेन वी से फर्म इन कंसिस्टेंसी, हाउ डू यू equalate the consistency, right? So when you say soft in consistency, touch your lips, किसी और का नहीं, touch your lips. The consistency that you feel on the lips is what we call it as soft. Touch the tip of the nose, this cartilage part. This is how a firm swelling would look like, right? This is how a firm swelling would feel like. Touch the forehead. Now when you feel the forehead, no, this is how a hard swelling will look like, or it will feel like. So soft, firm and hard. Fibroadenoma feels like this, right? Fibroadenoma is firm, right? So it is going to be smooth surfaced, hypermobile, firm in consistency, and this is how you know you're looking at the fibroadenoma of the breast. When you have a patient with the duct papilloma, patient will only present to you with bloody nipple discharge. Now, if you go back to our discussion of triple assessment, where we spoke about the various nipple discharges, I told you the most common cause for bloody nipple discharge is going to be duct papilloma. Here, patient presented with bloody nipple discharge alone. Along with that, not every patient, so few patients may or may not have plus minus palpable breast lump. They have palpable breast lump. So if you have a patient with duct papilloma, their primary principal complaint would be bloody nipple discharge. That's it. और कोई प्रॉब्लम है ही नहीं उनको. ठीक है. क्योंकि lump is not palpable, it is not feel because it's quite small. Usually we say it should be more than 1 centimeter to be able to palpate. Less than 1 centimeter lumps or lesions are very difficult to palpate, and hence the papillomas usually miss. Another problem with duct papillomas, they are usually, circumareolar, or they are usually behind the areolar region. ठीक है. So they're subareolar in region. Now, because they're subareolar, again it becomes very difficult to palpate them, right? Duct ectasia is the most dramatic one that you will have. So patient will present to you with periductal mastitis. Itis means inflammation, rubor, calor, dollar, tumor. So initially patient is going to present to you with mastalgia. They usually also have fever, and this usually is a low grade fever. So pain, there will be fever, so rubor, calor, dollar. Now, as there is edema, because of edema, the breast swells up, there is going to be an engorged breast. But all these tells you that there is an early presentation. Now, as this inflammation occurs repeatedly, repeated inflammation heals by fibrosis. So you will notice that all these ducts which are present, all these ducts which are present will slowly start to fibrose. So you will see there will be fibrosis of all these ducts which are present, right? Now, as there is fibrosis of all these ducts, I can tell you, because of this fibrosis, this condition is considered as irreversible. This is considered as irreversible because of the fibrosis of all these ducts which are present, right? So these are going to be fibrosis. See? Now, because of fibrosis, it is irreversible. The problem is not fibrosis. The problem is because of fibrosis, this condenses. Now, imagine all the ducts condense. Now, all them are going into the nipple. The nipple is going to be pulled inwards, and that's indrawing of the nipple in ductectasia has a very characteristic presentation called as slit-like nipple retraction. They will have slit-like nipple retraction. Right, so there is presence of mastalgia, there is fever, there is engorged breast, that is in earlier part of the presentation. Chronic may it will present into slit-like nipple retraction is going to be present. Now, what is going to happen because of periductal mastitis? As I told you, the inflammation is not inside the duct, it is around the duct. Now, because there is a lot of fluid that is going to be accumulated outside the duct also, all that fluid gets accumulated in the most dependent part of the breast, and the most dependent part of the breast is here, around the nipple. So, all this fluid, no, if I just say, because of inflammation, all the fluid that is present is now going to get accumulated in the most dependent area, and that most dependent area is just under the nipple. Now, obviously, this inflammatory fluid is rich in inflammatory cells. It causes the damage of the overlying skin, and all that staph epidermidis or other commensals which are present on the skin breaches inside, and they get infected, and that infection will result in subareolar abscess. That will result in subareolar abscess. And more importantly, what will happen? All that inflammatory fluid inside the duct mixes with the secretions of the breast. Along with that, because see, inflamed ducts will become friable and weak. No, and those friable, weak vessels or the ducts will bleed also. So blood with inflammatory fluid with breast secretions is now going to mix up, and when they mix up, they will present to you as a characteristic greenish nipple discharge. They present as characteristic greenish nipple discharge. Right? So you have mastalgia, you have fever, you have engorged breast, slit-like nipple retraction, subareolar abscess, greenish nipple discharge. All these goes in favor of duct ectasia. All this goes in favor of duct ectasia. Okay? So you had a patient who was presented to us with fibroadenoma, duct papilloma, duct ectasia. These are the clinical presentations that you look at. Now comes our phylloids tumor. Now, phylloids tumor are usually, it is unilateral, that is on one side. They usually present to you as huge lump in breast. They usually present to you as huge lump in breast. And as they grow very fast. So they are rapidly increasing in size. They rapidly increase in size and they remain painless. So these are the important points that you know in phylloids tumor, right? So you can have a patient with a lump in the breast, which is on one side, it is a huge lump in breast, rapidly increasing size, painless. When you look at this, it looks like malignant breast lump, but I would like to examine. So on examination, what do you see? The first thing I notice that the surface of this breast is nodular, right? It is not uniform, it is wavy, and this is what we call it as bossulated surface. Now, why bossulated? Because phylloids tumor is a combination of both solid and cystic component. The solid component grows very slowly, but cystic component grows very fast. So when the cyst enlarges, it will cause differential growth, and that differential growth will result in bossulated surface. Now, as it enlarges, right? As it enlarges, you see it is occupying one part of the breast, it is pushing the nipple onto the other side. We have already discussed the nipple deviation. If the nipple is deviated away from lump, it is usually a benign sign. So here you will see the nipple deviated. The nipple deviated away from lump. So usually you will see that the nipple deviates away from the lump. So when you palpate, no, as I told, phylloids tumor is a combination of both solid and the cystic component. When you touch, few areas would be firm, few areas would be soft. So firm, soft, firm, soft, firm, soft, this is how you'll feel it. So this is what we call as presence of variable consistency. There will be variable consistency. As the lesion enlarges in size, it compresses the lymphatics as well as it compresses the venous drainage of the breast. So hence you will see presence of engorged veins. So you have presence of superficial presence of superficial dilated veins. Now the last one, which is quite important, as the lesion continues to grow, it tries to stretch the skin. As the skin is going to be pressurized because of this rapidly expanding cystic lesions, it will cause pressure-induced necrosis, and that pressure-induced necrosis will result in ulceration over the lump, and this ulceration is due to pressure-induced necrosis. It is due to pressure-induced necrosis. So you have bossulated surface, nipple deviated away from lump, variable consistency, superficial dilated veins, and ulceration that is due to, or this is secondary to, pressure-induced necrosis. Now, when you have these presentation, now I've got all these presentation and I can create my own differential diagnosis, and I know what is the clinical presentation of my patient who has come for my expert advice. Now, when you have this, let's talk about the evaluation. Fibroadenoma of the breast, what is the first investigation? I would still go ahead with ultrasound. As I told you, any female age less than 40 years, the first investigation is going to be ultrasound. For duct papilloma under 40 years, it still remains as ultrasound. Duct ectasia is also ultrasound because it is mastitis. Any itis, that is inflammatory lesions, remember, mammography is contraindicated. So I'll go with ultrasound. And obviously phylloid tumor has cystic component, age less than 40, I will still go ahead with ultrasound. Hi Adya, I love you too. It's time for you to go to bed, right? So go sleep. I'll catch you up later. Guys, Adya is my daughter, so don't think there's some love story going on. It is father-daughter, and she usually comes to my class. I can't say no, she likes it. So why not? Okay? Good night, Adya. Good night. Good night. Chalo. Now, what is the investigation of choice, right? The investigation of choice for the fibroadenoma, we say if it is less than 25 years of age, you don't need to do anything. But if it is more than 25 years of age, get an FNSC done. For duct papilloma, you have to do something called as a ductography. As I told you, the most difficult thing in a papilloma is to localize it because it's a single lesion involving single duct. To find where exactly it is present, you have to localize it, and that is done by ductography. The ductography is you inject a contrast agent from the nipple into the ductal system, you do a mammography, and you map the mammographic image. Okay? In duct ectasia, initially you go with antibiotic management. Once the patient subsides of acute inflammatory phase, go with ductography. Now again in ductography, inject the contrast agent, map the ducts. You see multiple irregular dilated ducts are present, indicating it is duct ectasia. Whereas in terms of phylloid tumor, go ahead with true cut biopsy. Now fibroadenomas, to be very honest, you can leave it without doing anything, but I would like to tell you what are the current indications for surgery. What is the current indication for surgery in fibroadenoma? So if you're operating, just for the sake of discussion, I'll tell you the current surgery of choice. If you're operating on fibroadenoma, the surgery of choice, it is going to be enucleation. The surgery of choice for fibroadenoma is enucleation. What is an enucleation of fibroadenoma? Is you identify the adenoma, you open the capsule of the fibroadenoma, take the adenoma and suture the capsule back, is what we call it as enucleation. I don't want you to goof up on any of the following. This is what we do for the fibroadenoma. Now, what is the current indication for surgery? Number one, if the size of the fibroadenoma is more than 5 centimeters, as I told you before also, that more than 5 centimeters is what we call it as giant fibroadenoma. Number two, if the age of the patient is more than 30 years, then obviously, as the age increases, the probability of malignancy also increases. It can cause a diagnostic dilemma and delayed management. So age above 30 years is also an indication for surgery. The third indication for surgery is if there is a family history of breast cancer. If there is family history of breast cancer, I would not want, because this is a high risk patient, and tomorrow if she develops it, we will not be able to diagnose it earlier because we might think it is fibroadenoma. So avoid any diagnostic dilemma. You have to go with the surgical component. So family history of breast cancer, right? Another one, if there is any radiological abnormality. if there is any radiological abnormality or any form of suspicion, or on a histopathology, if there is presence of any atypia which can be present, and the last indication, if the patient wants it to be removed because of cosmetic issues. So cosmesis is also a very important criteria for surgical component, right? Clear? See, when you're helix, when you're trying to remove the entire lesion, no, that capsule will be adherent to lot of surrounding tissues as well, especially to the lobule. Now, when you try to remove it, one, it causes, because it's arising from the lobes, it will cause lobular destruction, and lobules contribute to the development or secretion of milk. In future, you are causing problem to that. Second, when you're trying to remove them, rather than excising them, there is a chance of damaging the other ductal structures also. So the risk to benefit ratio is poor there. On the other hand, when you do an enucleation, I'm very sure that I'm not going to damage anything else. I'm going to open it up, remove the entire component, and suture the capsule back again, causing minimalistic damage. So currently in surgery, we practice that minimal damage to normal tissue should be done. Okay? So these are the various indications for surgery that you have to follow in the fibroadenoma. And the surgery of choice is going to be enucleation. Now, in duct papilloma, you have to go with surgery, and the surgery of choice is what we call it as microdocectomy. So, in microdocectomy, what are you going to do? I am going to remove the major lacticiferous duct along with the papilloma. So I'm not only going to remove the duct papilloma, I'm also going to remove the entire major lacticiferous duct in which the papilloma arises. It has been observed that if you only try to excise the papilloma, one, repairing the duct becomes difficult. Second, the probability of recurrence is also there high. So hence remove the entire major lacticiferous duct. In duct ectasia, surgery is to be done. The surgery, see, rather than surgery, if they ask you what is the first line management in duct ectasia, the first line management is to start the patient on antibiotics, usually third generation cephalosporin, and once it's upside, the second line management is going to be surgery, and the surgery of choice is what we call it as Hadfield surgery. Now, what is an Hadfield surgery? In this, you are going to remove all major lacticiferous duct of the affected site. You're going to remove all the major lacticiferous duct of the affected site, not only the one which is probably looking ectasic, but even if there are 2-3 ducts which are ectasic, but you will try to remove the entire one because the other ones are in the form of making itself, right? So remove all the major lacticiferous duct of the affected site is what we call it as Hadfield surgery. Now, how would you like to address your phyllodes tumor? Now, phyllodes tumor basically depends whether you're looking at benign, malignant, or a borderline lesion. How do you know? So, on a true cut basis, we have a criteria to call it as a benign lesion. Either it is a borderline lesion or whether it is a malignant lesion. Benign, we'll look at the mitosis. If it is less than 4 mitosis per 10 high power field, it is benign. If it is 4 to 9 mitosis per 10 high power field, it is borderline. If it is more than or equal to 10 mitosis for 10 high power field, we call it as malignant. Now, if it is a benign or a borderline lesion, the current management says do a wide local excision. Do a wide local excision with 2 centimeter margin. Do a wide local excision with a 2 centimeter margin. That means you remove the lesion, but along with the lesion, 2 centimeters of the normal breast tissue should be removed. So if you're wondering what is this wide local excision is, let's say if this is a representation of the breast, this is the nipple that is present, and let's say this is the pectoralis fascia that is here, right? Now, I'm saying the phyllodes tumor is developed here. This is the area of the phyllodes tumor. I will mark the phyllodes tumor from here. From the margin, I will take a 2 centimeter radius, right? So the 2 centimeter margin has to be maintained throughout, and this much amount of the tissue along with the tumor will be excised. So when you take this out for the specimen, in the specimen you see this is the phylloids tumor that you have removed it. Along with this, this is the normal tissue around the phylloids tumor, you would have removed it. So what I'll do is when I send the pathologist, when I send it for histopathology reporting, my pathologist is not only going to say that whether the tumor is present or not, second he'll also tell you that this margin in every single direction is more than or equal to 2 centimeters. That means you've done a good wide local excision, right? So in phylloids, it is not 1 centimeter as margin. Here it is going to be 2 centimeter. That is going to be for wide local excision. For malignant, I will go ahead with simple mastectomy. I'll go ahead with simple mastectomy. I'm not going to do any modified radical mastectomy or radical mastectomy. The reason for doing a simple mastectomy is lymph nodes in phylloids are usually spared. Lymph nodes in the phylloids tumor are usually spared. So hence you don't need to do a radical surgery. You can get away with simple mastectomy. Now what is a simple mastectomy? When we talk about breast surgeries in detail, तब प्यार से आराम से फिर बताएंगे. But until now, this is the protocol that you have to remember. So next time you go to your ward, you go to your clinic, or you go to your internship or wards anywhere, you know there is a lesion, you know there's a benign disorder lesion or there's a benign lump, you have all the differential diagnosis, you know what are the characteristic findings, you know what will or how will they present to you. You also know the reason for each single symptom or each single clinical sign that you see. You reinterpret it with this and you know that you have the entire spectrum. This table is what is required for you as an undergraduate to know every single component of the breast. Now this is good enough for your NEET exam, for INICT, for your FMG exam, for your university prof exams, and if you're a resident, this should be on your tips, right? This is the basic that you should know. Yes, there's a little bit more onto it on a residency level, but otherwise more than enough, right? So thank you so much for joining today. I had a blast of a session, quite engaging as well. I personally love, interacting and teaching. If the chat box is buzzing, I would love to address with all the questions and queries. If you have any questions, queries, where to reach out, you can follow the Instagram that is called as the Surgery Guy, which is by name. It is Dr. Sandeep Seeram Reddy. So you get all the notes of all the BLS series which have been uploaded. So you have the same Telegram group and Instagram group on this name, and this is what you have. Okay. Thank you so much, guys. Thank you so much. Yeah, do join tomorrow. We'll continue tomorrow with the other smaller disorders. So tomorrow we'll be talking about the inflammatory breast disorders like acute mastitis, lactational mastitis, the other inflammatory disorders of the breast. We'll talk about gynecomastia a bit, and tomorrow we're done with the benign disorders of breast. Next week we'll start with the breast cancer. Do not miss it. If your friends, if you have your own peers or colleagues or juniors, please do suggest the BLS series. It is one stop to read your entire surgery. I had these questions and queries where a lot of students were asking, sir, how to use BLS. See, if you are a final year student or a third year student where you have not much to read right now, start following BLS. It is 1 hour a day, 3 days a week. This is what will require for you to complete your entire general surgery. Trust me, if you follow the entire series, by the time you go into your university exam, you will be pro at surgery. By the time you go into internship, you will crack it completely. And for NEET, PG, INICT, or FMG, you don't even look back, right? And all the students who are doing their MBBS abroad, you can also follow this BLS series because we start with very basic. We build concepts right from the anatomy to the surgical component. Okay? So use the BLS series, especially if you are in the final year or if you're in third year, if you're abroad, and all the residents who are watching. We are planning something for residents also. So we'll just add a lecture onto this. So whatever is there, I'll say in resident level, what additional things you should know. That will be one small lecture that we'll add on a week's time so that you get versed as well as utilize the same lectures as well, right? So thank you so much, guys, for joining. Tomorrow again, 9 o'clock, we'll resume back with our BLS series and try to hit you more tomorrow. Any questions, any queries, do feel free to reach out and give us queries, right? Any suggestions, any queries, always welcome, right? Thank you so much, guys. Good night. See you guys tomorrow. Take care.